Having me today, and I would like to congratulate the organizing committee, scientific committee, Dr. Sami for the successful event, really, and inshallah we'll talk about that later on. So the topic is like a bit of part of the complications that we'll have with the aging process, with the deformity, with the long fusion. So I will just go briefly because I know everyone is going exhausted after these 3 heavy days. So nothing to be disclosed. Usually this is one, I took it from one of the case reports because really if you go in the literature and you check and review the distal sacrum after the long fusion, you will have like some case series and some case reports, which is really, we don't have like a well-designed, established study, so it's only based on experiences. So those are the points that I will touch, like some of the biomechanics, diagnostic is very important, risk factors, then some ways of the interventions, and then the conclusion. So some background, lumbar fusions are one of the most common procedures performed by spine surgeons today. So usually lumbar fusions comes with like older patients, comorbidities and complications. So as always we are saying, spine is a field of complications. So you need to know the complications every day like a breakfast. So you need to know how to deal with those complications. So just some touch of the biomechanics if we have some area of fusion. So usually biologic, the neighborhood will be high stressful forces, and this will lead eventually to disc degeneration like ASD and spondylolisthesis, stenosis, and fracture. When those fusion or instrumentation combined with other factors like osteoporosis, which usually has like low threshold for the resistance to the fracture, or there's some obesity or some inflammatory process, you will have some distribution of the force in this area, so then you will have like a potential for fracture. And always L5S1 is like a dirty place to go, and there is like a pivot problems mechanism. You have instrumentation, you have hardware, fusion, alter the normal forces in this area, so you will have always failure, or most of the time failure of those segments, especially in patients with poor bone quality. And as we will see now in reviewing the literatures, the osteoporosis is #1 risk factor for those patients. So this is like Roy Camilli classifications for those fractures, and just focus on type 1 and 2. Those are most of the common for those fractures. So sacral fracture distal to the lumbar arthrodesis is challenging. Why it's challenging? Because always complicated by issue like lumbosacral alignment, pre-op and post-op, the pelvic morphology per se, and global alignment and bone quality. And if you have more pelvic ring extension, this will complicate the issue more. So just go for some part of the literature, and as I said, it's like reports or some small case series, but we need to have some experiences from those, because at any day, at any one of our procedures, lumbar fusion, you'll have these complications once a year or once every few years. So this is like a case series of 53 patients. They have more than 5 level fusions. They have spinal kyphoscoliosis, and at least 2 years of follow-up, 2 groups, 1 group, non-iliac group, they labeled it, like stop at L5 or S1, and this is also make some bias, and ilium or iliac group. They want to investigate most of the complications like instability, pseudoarthrosis, screw loosening, sacral and rod fracture as well. And they came up with like long lumbar fusions, at least 5 levels had lesser failures when stopped at the ilium when compared to stopping at L5 or S1, to avoid sacral fractures. Another case series of 9 patients, they have from 1 to 8 motion segments. So this is really, there is like a bias also here. They have some data here. 6 patients had like a diagnosis 5 weeks after the surgery. 3 patients have diagnosis like 8 months, and CT for all of the patients. They interfere with 2 early surgeries because of the displacement, angulations, and massive pain there. And 7 patients underwent like non-operative. So 3 have like healing with brace, and 4 they could not tolerate the brace. They did like posterior approach, decompression, hardware revision, and lumbo-pelvic segmentation, which is important. So you need to extend according to their recommendations. So all surgical patients demonstrated fracture union and were able to walk, but there was like a lot of complications even with those patients. So they came with some incidents. They have like, if you have short segment fusion, you will have like 1% of this complication. If you have long fusion, this will raise up to 3%. But they concluded that it's very rare complications. Non-operative might help in those patients. Another study also, they suggest elderly osteoporotic patients undergoing multi-level lumbosacral fusion with rigid instrumentation may be at increased risk of early postoperative pelvic and sacral stress fractures. This is like discussed in the conference already, so where to stop? At the sacrum. I will not go again for that. This is another series also, and they found some risk factors like osteoporosis, obesity, sagittal imbalance, and so on. And the surgery should be performed in patients with symptomatic. So try your best to avoid the surgery or revision surgery. If there is like a crack fracture, or you try all the way for like non-operative management, like bracing or pain management, protected weight bearing, and so on. Because there is like a lot of problems with the complications with the revision as well. This is just showing that the transverse sacral fractures in 2 case reports healed well with brace and pain management. So the incidence of spine fracture after fusion in general reaches like around 12%, but with the Wood classifications, it's like around 2% for the sacrum fracture. So just to summarize things, risk factors, so you elderly patients, multi-level surgery, long fusions, osteoporosis, obesity, sagittal imbalance, chronic corticosteroids, and prior radiotherapy. Osteoporosis, it's very important to evaluate the patient pre the first primary surgery. You need to do be careful with the risk patient or risk procedures. But even though they have in some series some normal BMD, and they do have some fractures. So even osteoporosis needs more workup to just confirm these conclusions. Diagnosis, this is very important. If you have post-op patients, continue have a pain, persistent pain, botic pain, radiculopathy, you need to have high index of suspicions, because the conventional radiographs, it's around 10% so to diagnose those things. So CT scan is the module of diagnosis. Non-surgical management, control pain, you need to do to rule out pseudoarthrosis. And sometimes if you are doing CT scan and you find pseudoarthrosis and fracture, you don't know which one is first. Is it from the pseudoarthrosis or from the fracture? And this is to complicate the things more. Without neurological deficit or displacement of the fracture as well. Brace versus non-brace, this is also, you always see if you are bracing the patients and put in the bed or protected weight bearing, you have some complications like DVT infections. So this is also another things. Surgical management, just to summarize the surgical management, majority of the patients indicated for persistent pain and displacement of the fracture. And usually the standard is extension of the fusion to the iliac, using iliac screws or S2 ala screws. Some studies showed supporting from the anterior, especially if you have pseudoarthrosis, and you need to apply the pseudoarthrosis principles. Just before I end I will just take you through this case during my fellowship. We have this patient, she's around 60-year-old, heavy smoker, overweight, and I did not know if she's having BMD problems or osteoporosis. She had this spondylolisthesis. She underwent open reduction and decompression, the usual standard. Few weeks later, she had the level below with the spondylolisthesis, so she was revised again. Then after that, she had 6 or 7 weeks. She came back, post-op, she had hematoma, so this is in the way with the complication, so evacuated. Then she presented with this fracture. So Again, she was having like CT scan, and then to the ileum. Then after that, she came with the ASD above and revised again. So this is really summarized most of the problems in one case. So this is why it's like L5S1 is very hot area. If you are going to or deciding to do some surgeries there, you need to plan and revise and replan and reassess all the aspects. So just to sum up, it's a rare complications, but it's really painful for the surgeon and for the patient. Meaningful complications, we need to analyze the risk factors. Non-operative, there is some rule. Operative, individual evaluations, fracture morphology, degree of patient symptoms, medical comorbidities, risk of revision, always to weight it against the non-operative, and also the surgeon experience. And we don't want something like going from this to those pictures here. Thank you very much.